and also the NW Network Director, Research Delivery Network, NIHR. And he is also consultant in infectious disease, the Regional Infectious Disease Unit, North Manchester General Hospital, Manchester. And he is the MAHSC Honorary Clinical Chair, Faculty of Biology, Medicine and Health, University of Manchester. He got his MB and Bachelor of Science from University of London, and also got the MRCP Royal College of Physicians, UK. And later on, he also got the PhD degree from University of London and the FRCP Royal College of Physicians, UK. And original, his medical school is Guy's Hospital Medical School, London, UK. And he has a lot of research activity. Is the PI on over 120 studies, and he is the UK chief investigator on over 20 multinational studies. I think Andrew is an expert in the research area, and he is today is going to give us a lecture on from the UK to the world, expert insights on COVID-19 treatment optimization. Let's welcome Professor Andrew.
Thank you very much. Thank you for the very kind introduction. I'm an adult infectious diseases doctor as well, and so when COVID hit, I was fully brought into the front line as well as on the research side. And I was fortunate enough to lead the UK's COVID vaccine research program, as well as being part of the recovery study and a whole variety of other studies that were part of that. So almost overnight, my life pivoted towards COVID. And thank you very much for the invitation to come and speak to you today. I will be using some of the same data as the previous speaker, but probably putting a slightly different slant on some of the topics. So this is the disclaimer, which is basically saying the opinions are mine and not Pfizer's, and I'll be saying what I think. So early 2020, most parts of the world suddenly found that they were having to deal with cases such as this. And my regional infectious diseases unit, I happened to be on the wards when the first patients came in. We normally have 2-3 wards, and within about 5 weeks, we had 7 wards and 3 intensive care wards full of people with the new disease, which was subsequently called COVID-19. Since early 2020, we've learnt a lot. We've learnt about the virus, we've learnt about treatments, and obviously we've made huge progress with vaccinations. And that isn't the only thing that's changed our knowledge. The virus has changed. Now, you've seen this, or a version of this already, but I want to make some different points. The virus has changed over time, and this is what we expect to happen. We fully expect new variants to appear, and in fact, at a higher frequency than we would normally expect an infection to mutate, because this is a new pathogen in a new host. And so it's under a lot of immune pressure to adapt and change. And that's why we've really gone through the wild type, alpha, beta, gamma, delta, and then Omicron. What is interesting in terms of the evolution is that beta did not come from alpha. Beta came from the wild type. And gamma did not come from beta or alpha. It came from the wild type, as did delta. Now, since we've been in Omicron, there's been evolutions in Omicron. But that is important potentially for the future, because we could get a completely new variant appearing. Now, we've seen this slide already. This is looking at the more recent variant, 181, and the sudden spike in cases that have occurred around the world, but most predominantly in this case in Hong Kong. And you've also seen this slide. But the point I want to make here is that we do expect new variants, and by definition, those new variants will either be more infectious or more prone to immune escape. Otherwise, they wouldn't be an emerging variant. So every time we see a new variant, I do expect infectivity to go up, or infectiousness to go up, or immune escape to go up. But what isn't a given is that pathogenesis or pathogenicity, how bad, how virulent the virus is, will stay the same. Over a long period of time, and I mean decades to centuries, a new virus entering into a host will tend to attenuate and become less virulent. But actually, our time span is far too short. And we have just been lucky that in many ways, Omicron is less virulent than some of the earlier versions. Whatever comes next, and my Greek alphabet is not good enough to know what comes after Omicron, but whatever comes next may well be more pathogenic, more virulent, and cause more issues. Now, I briefly want to talk about data here. We've got some data on hospitalizations in Asia at the end of last year, and you can see, I hope, that the rates in Southeast Asia and Western Pacific are significantly increasing. But the absolute numbers are quite low. That doesn't put me off because there is a huge underdiagnosis, significant underestimates. It's difficult to actually tabulate how much these are, but if we look, and this is WHO data, at where there has been wastewater examination, wastewater surveillance. So in other words, taking the wastewater from the sewers and looking how much virus there's in there, then at an underestimate, most of us think, we're probably underestimating the numbers by about 19 or 20 times. There's an awful lot more SARS coronavirus 2 out there than we are detecting because we're not generally doing diagnostic tests. Now, I know we've touched on these, but again, I want to make a few points, really. So, first of all, this graphic. So we have got the peak, but going back to what I said about new variants emerging, we will get similar peaks in the future. We cannot take our eyes off COVID-19. At any stage, rates may go up and it may be more pathogenic. And I wanted to make the point here that often in guidelines and in publications, people use cutoffs. 65 years, I think, is your routine age. It isn't binary. It isn't when you're 64, you're protected, and when you're 65, you're prone to severe disease. So we do have to take a bit of clinical acumen here and balance these, albeit we have to follow guidelines. But you can see here significant numbers of people in their 40s. And I'll pass over that. So let me introduce Lee. Lee is in his late 40s and he has asthma. It's not particularly bad asthma. He had one hospitalization 10, 20 years ago. He's had occasional courses of oral steroids, but nothing recently. And Lee does not view himself as unwell or having a morbidity or being at risk of anything. He feels himself as being a normal part of our community. But this is what happens to Lee. He ends up on intensive care, mechanically ventilated because of COVID-19. So what can we do about this? Well, first of all, we should consider someone like Lee potentially at risk. So we've touched on some of the major risk factors related to COVID-19, and we discovered these quite early. So advancing age generally in most populations is the most significant risk factor. But underlying health conditions, including immune suppression, and I want to talk about immune suppression later on. If you're not protected by vaccines, not up to date with your vaccines, you're more prone to severe COVID. Some migrant and ethnic minority populations have a higher rate of COVID and severe COVID, but that is largely, if not exclusively, related to socio-economic factors. Pregnancy, smoking, and living in long-term care facilities. Now, in here, no longer is hypertension and some of the softer risk factors we had in the first wave. So let's go back to Lee. What we really want to do is prevent this outcome with him on intensive care. So COVID, in terms of interventions, I think is a relatively easy disease to think about. And it's this graphic based on what was called the Siddiqui diagram, which was right in the early part of 2020 in the first global wave that it was developed. And it identified that there were three main phases of infection. An early infection phase with viral type symptoms, a pulmonary phase where people develop a pneumonitis and start requiring oxygen supplementation, and then a hyperinflammation phase. Not everybody progresses through all of these. The pathogenesis is different. Early on, it is viral replication with relatively little inflammation, and later on, it's a lot of inflammation with relatively little viral replication. And the treatments, therefore, depend where you are on this pathway. And what treatments do we potentially have for COVID-19? Well, if you think about the diagram I just showed you, we have two main groups, antivirals and immunomodulators. Antivirals used early, immunomodulators used late. Immunomodulators listed here, I'm not really going to talk about them. The antivirals, in my practice, three main: remdesivir, nirmatrelvir, ritonavir, Paxlovid, and molnupiravir, which we no longer use, which I'll touch on. And grayed out on the left side there are the neutralizing monoclonal antibodies, because as the previous speaker said, against the variants we have now, there is not significant enough activity. So what can we do at this early stage to prevent Lee worsening? When he first presents to one of you saying that he's got viral type symptoms, a cough, runny nose, headaches, fever, what can we do? Well, the predominant pathogenesis is viral replication, so we need to think about antivirals. And the three main antivirals that I mentioned, four in a way. We've got the neutralizing monoclonal antibodies, which act at the top, but they're no longer active against the spike protein we have at the moment. We've got protease inhibition, which is where Paxlovid works. And we've got RNA-dependent RNA polymerase inhibition, which is where remdesivir works. And molnupiravir is supposed to work by creating catastrophic mutations in the genome replication. Now, the reason I said we don't use it, and the reason I said it's supposed to work that way, is I think, at least from the UK point of view, we don't think it works. We did a big study, the panoramic study in community, which showed no significant benefits other than people feeling better about half a day earlier, but not enough to make us use it. And actually, if you go back to the original move-out data, the licensing study, the first cohort showed a significant difference, but within the same study, the latter cohort had lost any significant impact of the medication. So we no longer use molnupiravir. Now let's talk about Paxlovid. You've seen a different version of this data. This is the EPIC-HR data. This is the licensing data, randomized controlled study, phase 3. And what I hope you can see is that if it's given to adults at mild or moderate risk of COVID, with mild or moderate COVID at high risk of progression, within 5 days of symptom onset, we get an 88.9, an 89% relative reduction in hospitalization or death. And those aren't the only endpoints, as we've seen. 82% decrease in those needing oxygen supplementation, and actually no one who was on the Paxlovid arm required ventilation or wasn't discharged home or ended up on intensive care. It isn't the only drug that can do this. I've said I don't believe molnupiravir works well, but remdesivir, another antiviral, had a very similar success rate, 87% relative risk reduction in the same endpoint if given within 7 days of symptom onset. The problem with remdesivir is it's intravenous for 3 days, and therefore it is not logistically very easy to deliver to people in the community like Lee. Those are the major randomized controlled studies that I think are relevant if we're talking about someone like Lee. But importantly, we increasingly have to look at real-world evaluation. Randomized controls trials are really important. High-quality evidence, less confounding, needed for regulatory approval. But real-world evidence is needed generally in most areas to tell us about how generalizable the results are. What about particular subsets that weren't well represented in the original studies, etc.? But also, really importantly, in this disease, those randomized controlled studies were done with different variants now several years ago. And we need to keep an eye on the real-world evaluation studies in order to show that efficacy is still ongoing. And the good news is, for Paxlovid, that's the case. This is too small for you to read, but it doesn't matter. On the left is EPIC-HR, the study that I said, and here are just a selection of 6 other real-world evaluation studies, largely done more recently, showing very similar efficacy. And we've got the Hong Kong data. So this was a very large bit of real-world data, looking at over 1 million people, of which just over, well, almost 6,500 received Paxlovid. And you may not be able to see, but there were significant, very significant improvements in all-cause mortality, hospitalization, and in-hospital disease progression, with hazard ratios of 0.34, 0.76, and 0.57. So very significant improvements in this real-world setting, not too far from here. And we've already seen this data for the real-world evaluation in Taiwan, but I want to call out again the very significant impact of treating the right people in a timely manner with Paxlovid, with a risk of intubation down by 70%, similar decrease in risks of ICU admission, and an 80% decline in the risks of death. So real-world data supports the randomized controlled studies and is more applicable to our populations and also more recent variants. Now again, we saw this data looking at people who are unvaccinated, received 2 mRNA doses or 3 mRNA doses, and on the left didn't receive Paxlovid, and on the right received Paxlovid. And the point I want to make here is I hear all the time that we don't need to give an antiviral to an at-risk patient because they've been vaccinated. Yes, you still do need to give an antiviral if they are high risk of progression. The numbers of people progressing if you're vaccinated will be less, but the matching, if you match the different vaccination statuses to the Paxlovid, you see there is still an incremental improvement, an incremental benefit of giving Paxlovid, even if you're fully vaccinated, if you're a high-risk patient. Don't worry if you can't see this. I could have chosen many other graphs here. It's to say that antivirals, here Paxlovid, but actually it would work for remdesivir, it would work for other antivirals. They work across the cohorts. They work across the subsets of individuals. So whether it is chronic lung disease, chronic kidney disease, neurological disease, diabetes, etc., there is that same impact. I particularly, however, want to call out people who are immunocompromised. Now, one difficulty we have when we talk about immunocompromise is, as doctors and healthcare workers, we often view people as immunocompromised or not immunocompromised. That's not right. You know, there are huge variations in the degree of immunocompromise depending on your underlying disease or your therapies. So the problems that I have in clinical practice are those, oh, my word, are those that are solid organ transplant recipients, stem cell transplant recipients, and actually, personally, particularly those on rituximab and B-cell ablative therapies. They are so much more at risk of severe COVID than someone who is on steroids, or indeed someone who is HIV positive with an undetectable viral load. That latter group, my background is HIV medicine, if someone's got a reasonable CD4 count, an undetectable HIV viral load, I view them at the same risk as the general population. It is very, very different. But if we do lump all immunocompromised together, what do we find? We find increased susceptibility to infection, impaired ability to recover from infection, obviously an interplay with other risk factors because these people have other issues, prolonged high viral load, prolonged infection, and viral shedding. And that prolonged infection is the real key of the difficulty with this group. Insufficient impaired response to vaccination and susceptibility to co-infections and secondary infections. So what about real-world data of using something like Paxlovid in those people with hematological malignancies, people with systemic autoimmune rheumatic diseases, largely on immunomodulators, and solid organ transplant recipients. Well, the benefit is still there, and in fact, the benefit is very marked. So if we take hematological malignancies, your mortality dropped from 11% to 2% by giving Paxlovid. If we take those people with rheumatological diseases, largely on immunomodulators, the severe COVID dropped from almost 18% to 2%. And if we take solid organ transplant recipients, then we had a drop in hospitalization or death from over 30% to 14%. So we absolutely need to be giving an antiviral in these individuals. So what about how to prescribe it and what to do about drug-drug interactions, which we've touched on a little bit? So you've seen how to prescribe it. It's for 5 days. It comes in nice packs, which are quite easy to use. It is 2 tablets of nirmatrelvir and 1 tablet of ritonavir in the morning and the same in the evening. You may need to dose adjust in renal, as we've touched on already. Hepatic impairment, well, actually, those with mild or moderate hepatic impairment can just go ahead and have Paxlovid. It's only when it's child PUC that you really need to worry. But what about drug-drug interactions? Well, my background, as I said, is HIV, and I'm sure some of you, or I know some of you in the audience are HIV practitioners as well. So we're very used to drug-drug interactions with the ritonavir and with other medications. What's important is drug-drug interactions can go both ways. So there are interactions which could decrease the efficacy or impact on Paxlovid, but actually more relevant for day-to-day clinical practice is the impact of Paxlovid, and particularly the ritonavir boosting, on other medications. And there's a long list of different medicines that can cause problems, and I'll touch on some of those in a second. But what I'd advise you to do is not necessarily keep it in your head all the time, but to use a resource. So the University of Liverpool do the HIV drug interactions website, which is generally used around the world, but they also have a COVID-19 drug interactions. And if you put your COVID drug, in this case Paxlovid, all the co-medications, and you press the button here, then you get red, amber, or green of all the medications. And red means there's a very significant drug interaction, amber means there is an interaction, and green means nothing very much at all. But importantly, when it's red or it's amber, you can usually click on it, and it gives you the background information, and sometimes gives you an idea of what to do about that drug-drug interaction. So if we take some of the significant drug interactions that are often listed, you can see here cardiac medicines, anti-epileptic medicines, rifamycins, but also things that actually are more commonly an issue, such as some of the statins, simvastatin, etc. Now, what you do about these drug interactions can be multiple. So it might be all you need to do is increase the monitoring for potential adverse events, in which case go ahead and just do that monitoring. It could be you can adjust the dose, or you should adjust the dose of the concomitant medication. That's slightly less common, but it is there, and we sometimes do that. What we often do is just temporarily withhold the concomitant medication, not if it's a cardiac medicine, or it's an anti-epileptic, or you're needing TB therapy. But if you're on simvastatin, does it really matter if you stop that statin for 2 or 3 weeks and then recommence it? Absolutely not. So what I'm trying to say is, just because something's red, don't let it put you off using the medication. Dig down, do they need that medication? Can you dose adjust, or how do you need to monitor? And as the last resort, think about alternative COVID-19 therapies. Long COVID was touched on, and I'm not going to reiterate the same points, but I want to make some other points. Long COVID is a huge issue. We have long COVID clinics. We have a whole population, subpopulation within our communities with long COVID. My own view is long COVID is not one disease. There are many phenotypes, and I think there's probably many pathogenicities, many causes of it. And so it's not surprising we don't have a single magic bullet as yet for long COVID. I think we'll end up with several not quite so magic bullets to treat the different phenotypes of long COVID as time goes on. But what can we do about long COVID? Well, it was alluded to earlier on. Long COVID is more frequent. if you have more severe disease. So what we need to do is prevent disease completely or abrogate the severity of disease if we can. If we really want to attack long COVID and prevent new long COVID, make sure our populations are vaccinated as much as we can. And I note the 10%, 20% rates. So what can we do about that? The vaccination, even if you catch the disease, if you're vaccinated or partially immune, it's likely to be less severe. But giving an antiviral, whether it's remdesivir, whether it's Paxlovid, can decrease the rate of long COVID across the different phenotypes, as we saw earlier on. So my final thoughts really on pathways, because it's fine, you know, we've heard the data. We know viral pathogenesis early on. We know there are antivirals that work, randomized controlled studies, real-world data, current variants, not just previous variants. But where it often goes wrong around the world, including in my unit and in my area, is implementing that knowledge in direct practice. So, what are my thoughts? We have to rapidly consider the diagnosis, and I don't think we're doing that as often, whether we work in emergency medicine, whether we work as a family doctor in the community, whether we're a healthcare worker on the wards. We're not necessarily thinking about COVID-19 as people first present to us. And we can't do anything unless we consider the diagnosis. Once we've considered the diagnosis, we need a rapid diagnostic test, not something that takes 2 days to come back, because there's data that says every day of delay of an antiviral increases the mortality somewhere between 10 and 20%. We need a rapid diagnostic test that returns quickly. Once that returns, we need someone with the skills and the knowledge to rapidly triage that individual to know if they're high enough risk to meet the criteria for an antiviral or for intervention. And then we need that prescription to be rapidly written and rapidly delivered, not delivered the next working day because pharmacy's closed and they can't access the medications, because that delay is important. And then obviously we need close assessment of progress. Now I want to pull out rapid, 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 rapid. We were doing this during the height of the waves. Almost every unit I visit, almost everybody I speak to will confess to the fact that things are so much slower now. And that's not to the benefit of our patients or our healthcare systems. Thank you very much.
A panel now.
Okay.